So this was all about the clavipectoral fascia. Now we will move on to the posterior axioappendicular muscles, starting from trapezius and rhomboids and all these muscles. Let us start with the trapezius muscle. This is a very large muscle that is present on the back, and as you can see in this model, it together with its counterpart muscle on the opposite side, this make this trapezoid shape. That is why this is given the name of trapezius muscle. This is a very large muscle. We will see its extensive uh, attachments. So there are two muscles, and it attaches all the way from skull down to the ribs, down to the vertebra, all the way to thoracic vertebra. Let us isolate its origin and insertion. So let us start its origin from here. It is attached to the this ridge on the back of your head that you can palpate. This is the superior knuckle line, and then there is a prominence in the midline here. This is the external occipital protuberance. From here to here, the origin is not shown, as this origin is not bony. It is attached to a ligament. I will show in the picture, superior knuckle ligament. Then it is attached to the all the thoracic vertebra, and it is attached to the tips of the spines. As you can see, its attachment here on the tip of the spine of all the thoracic vertebra. Then from this vast origin, it gets inserted into scapula and clavicle. On the scapula, it is attached to the root of spine of scapula. It is attached to the superior lip of spine of scapula. Then it is attached to the medial aspect of acromion process, and that is attached to the posterior aspect of the lateral 1/3 of the scapula. So here in this picture from Grant Atlas, you can see most of this. So here it is attached to this super knuckle line. Here it is attached to the external occipital protuberance from here to here. So it is attached to the knuckle ligament. It is somewhat shown here. This, sorry, like this. This is the labeling, and you can follow it to this knuckle ligament. It's basically a ligament that is present like in this way. It is present between the concavity, posterior concavity of the cervical vertebra and the posterior midline, and it is attached to here this knuckle ligament, and then it is attached to all the thoracic vertebra down to 12th thoracic vertebra, and its insertion is on the root of the spinoscapula, superior border of the spinoscapula, the medial aspect of acromion, and the posterior aspect of the lateral clavicle. So if you try to understand it, its function will become very evident. We can divide the muscle into three parts: the fibers that are approaching from the superior aspect, the fibers that are approaching from the horizontal aspect, and the fibers that are approaching from the medial aspect, from the inferior aspect. So these horizontal fibers are majorly responsible for bringing the two scapula together. They are helping in retraction of the scapula or adduction of the scapula. Then there are fibers, and be very aware that we are talking about this part of the muscle, the descending fibers, not the highlighted part. This is responsible for pulling the scapula upwards, so it is helping in elevation of the shoulder, shrugging of the shoulders. So even if you are sitting at rest, thus the maintained part of the scapula, it is due to these muscles. When you shrug the shoulders, it is due to trapezius, and even if a person is sitting still and they have one trapezius, one part that is affected, then that will be a drooped a little. So we talked about the horizontal fibers having adduction, that fibers from above descending part elevating it, and the fiber that is down at the ascending part depressing the scapula. But magic occurs when these parts work together. As you can very well see, the descending part are majorly attached to the lateral aspect of the spine or acromion process. So they pull up, and this part, the ascending part, they pull down here. So when mm, downwards pull is on the medial end and upwards pull is on the lateral end, this helps in the rotation of scapula. This helps in rotation of scapula, and this rotation becomes very important when you are doing overhead abduction. So this is the one of the two muscles that is doing overhead abduction. The one that we saw earlier in this lecture was serratus anterior, and the second one is trapezius muscle. So here comes a question regarding the injury of the trapezius muscle. It is, by the way, supplied by spinal accessory nerve. I did not show that. Let me show you that first before discussing the injuries. It is supplied by the spinal accessory nerve, and as you can see, I have discussed it in detail in my cranial nerves lecture. But you can see as it comes down from the skull, it supplies sternocleidomastoid and that supplies the trapezius muscle. So as you can see, it is coming down from the this area. So this is the posterior triangle of the neck. Again, the triangles are discussed in detail in head and neck lectures. So it is coming down from the skull all the way, supplying sternocleidomastoid and going to through the posterior triangle of neck to supply this trapezius muscle. So this is the trapezius muscle. So now the question that I was talking about, the question that bugs the students a lot is how to differentiate between the injury of the two muscles, both of those who are responsible for overhead abduction. You may be given an MCQ regarding a person is unable to comb her hair, a person is unable to reach the top shelf of her cupboard, but now which nerve is injured? Is the accessory nerve supplying trapezius is injured, or the long thoracic nerve supplying serratus anterior is injured? So the answer is to look for the cues in other functions or attachments or place of injuries. For example, if you are given a question scenario regarding the inability to overhead abduct along with winging of scapula, then this is serratus anterior. There is inability to overhead abduct along with the drooping of shoulders, then this is trapezius and long thoracic nerve. Sorry, and accessory nerve. Again, with the site of injury, if there is an inability to overhead abduct after a surgery of the neck, then we are talking about the injury of accessory nerve and posterior triangle. If there is inability to overhead abduct after radical mastectomy where the breast tail was removed here, then there is an injury of long thoracic nerve. So that is how you can differentiate between the injury of long thoracic and accessory nerve. This brings us to the latissimus dorsi. So this is the large expanded muscles, the latissimus dorsi. It is the one that is arising from the back, and you can see this is the only muscle that arises from the pelvic girdle too, and it fans around the lower chest, comes around and gets inserted into the floor of the bicipital groove. Let us isolate its origin and insertion. Its origin from the lower aspect of abdomen is majorly through thoracolumbar fascia. I will show you again. And through thoracolumbar fascia on the iliac crest, and through thoracolumbar fascia on the thoracolumbar fascia to the lumbar vertebra, and directly attached to the lower thoracic vertebra. Then it has some slips that originate from the ribs also, lower few ribs, lower 5 or 6 ribs, and then goes up, may have some origin from this lower end of the scapula too, and it has insertion on this floor of the bicipital groove. So let me show you the muscle here again. So here it is through the thoracolumbar fascia, it is attached to the this area iliac crest. Through thoracolumbar fascia, it is attached to lumbar vertebra. Directly, it is attached to the lower 5 or 6 thoracic vertebra spine. Then the horizontal fibers go horizontally, may get attached here to the lower end of the scapula. Beneath it, they are attached to the lower few ribs, and as it goes, just like pec major, it winds around and turns around itself. Like, let me show you, let me try to show you here. As you can see, the fibers go turn around the undersurface of this muscle teres major and gets attached to its lateral aspect and to the medial aspect of pec minor. So this is the attachment of Latissimus dorsi. Due to its approach from the medial aspect, this muscle is a very powerful adductor of the shoulder joint. As you can see, it can pull the humerus along with the scapula. It acts as the adductor of the scapula as well as adductor of the shoulder joint. So in this particular aspect, you are only isolatedly shown the adduction of the scapula, and here you are shown the adduction of the glenohumeral joint. You can notice the movement of scapula beyond it too. So this muscle is very much important in pulling the arm from the abducted position in the adducted position, as it is occurring against the anteroposterior axis. So due to this very powerful movement, this muscle is also called climbing muscles of the body, because when you have head overhead abducted, you pull it down, you can bring the muscles here. When talking about the horizontal axis, as this muscle is lying on the posterior aspect of the horizontal axis, it pulls the humerus back, thus helping in extension. So it is lying back, so it is helping in extension of the shoulder joint. We talked about adduction, extension, and now there is medial rotation, as this muscle is getting inserted onto the anterior surface of humerus. When the anterior surface of humerus is pulled medially, it helps in medial or internal rotation of the humerus. So these are the functions of the latissimus dorsi. This muscle is responsible for extension, adduction, and medial rotation. That is why that helps in the climbing in the body. And also one more function that was not discussed, due to its sense of encompassing the body, this muscle when contracts, it pushes the ribs inwards, that helping in forceful expiration. So when you cuff, this muscle also helps in cuffing. It pulls the ribs downwards. And you may have experiences when you have prolonged periods of cough for a periods of few weeks or a few days. You may feel soreness in this part due to the latissimus dorsi. And counterintuitively, this muscle is responsible for forceful inspiration too. For example, when you have a fixed humerus, when you have put your arm here and when this muscle is contracted, do you remember the origin points were on the few ribs too? So the origins on the ribs are pulling against the fixed humerus, and they may help in elevating the lower ribs. So it may help in elevating the ribs too. So this is about it. And yes, I think I failed to mention the innervation. This muscle is supplied by thoracodorsal nerves that comes from the posterior cord of the brachial plexus. So as you can see, it is made by three divisions. This is the posterior cord and thoracodorsal nerve. Not going into its path right now, but it gets down and get inserted here, and its arterial supply is majorly through the lateral thoracic artery, or it has the branches here. As you can see, it has a supply from the branches that are supplying the posterior back, but thoracodorsal artery, that is one of the major supplies of the latissimus dorsi. Thoracodorsal artery, it's the branch of subcostal artery, sorry, the branch of subscapular artery, the third last branch of axillary artery. So it extends down to supply this, and this arterial pedicle is very important, because in sometimes reconstructive surgery, sometimes breast surgeries after mastectomy, this muscle is pulled up from its origin, and this supply is maintained, and this nerve supply is maintained, and this muscle is brought to the front of the chest to act as a prosthesis. Now this surgery is relatively less common due to the better prosthesis availability. So this is about it. So this is the latissimus dorsi. We talked about its injury, and yes, there are two triangles that are important here. One triangle is this one, that is the triangle of auscultation. It is created between the lateral border of trapezius, the upper border of latissimus dorsi, and this medial border of scapula. The lateral border of trapezius, upper border of latissimus dorsi, and medial border of scapula. This is the triangle of auscultation, because here the number of muscle layers and the scapula are away, so the chest wall is thin here, and you can better hear the sounds if you place your stethoscope at this point. And on the back, if you see here, you can see the lumbar triangle of Petit. So here on the back there is latissimus dorsi. Let me put it here again. On the back there is here latissimus dorsi and thoracolumbar fascia. On the front there is external oblique muscle, and below there is iliac crest. So this area, this is the lumbar triangle of Petit, and internal oblique muscle is making the floor of it. And this is clinically important because this part present as a little weakness of the abdominal wall, and hernia may start from this point. So this is all about latissimus dorsi. Now we are going to discuss the three muscles that are on the back: levator scapulae, rhomboids minor, rhomboids major. I think these are simple enough. I won't be going into the models very much, but let me discuss it. Let's just talk about the levator scapulae. This muscle, it is proximally attached to, or its origin is from the transverse processes of C1, 2, 3, and 4 vertebra. The muscle fiber comes down from here, and it is attached to the medial border of scapula above the spine of scapula. So this is the transverse process, C1 to C4, and it is attached here. So as the name indicates, this muscle helps in pulling the scapula upwards, so it is helping elevator of the scapula, and it is supplied by dorsal scapular nerve, and that's the nerve that comes from the brachial plexus and comes right down here beneath this muscle, running down, supplying all these muscles, and some direct branches from the cervical plexus. And there is a thing that I did not discuss with trapezius, but we'll discuss it here. If the scapula is fixed, it can help pull the neck laterally. So trapezius, similarly, when talking about the upper limb, would think about its functions as the mover of the upper limb, but if the limbs are fixed, then this muscle can help in laterally flexing the neck too. Next, rhomboids minor and major. Rhomboids minor arises from the lower cervical and upper thoracic vertebra C7 and T1, and from here it is attached to the medial border of scapula just against the root of the spine. So this is rhomboids minor, and then there is from T2 to T5. This is T2, and this is 3, 4, and 5. This is T5, and so below, and it is here inserted into the medial border of scapula on its posterior aspect from the root of the spine all the way to the lower angle. So this is the rhomboid major. So these are very flat muscles, and these muscles along with the levator scapulae are supplied by dorsal scapular nerve that comes from here and runs underneath these muscles right here. So this is supplied with a dorsal scapular nerve. So here is levator scapulae muscle followed by this rhomboids minor and this rhomboids minor and rhomboids major muscles. With rhomboids major and minor, major is responsible for this retraction of scapula shown right now, and levator scapulae helping along with trapezius upper fibers are descending fibers to help elevate the shoulders right here. And this was the nerve, the dorsal scapular nerve that I was talking about, coming from the brachial plexus and going down near the medial border of scapula right here, and underneath this rhomboids minor and rhomboids major. So this was about the nerve supply of these muscles, all three muscles. So here is a comprehensive picture of the muscles we have discussed. In the posterior aspect, we talked about this large muscle. This was trapezius, and we talked about its function of descending fibers, horizontal fiber. We talked about the retraction, rotation of scapula functions, its nerve supply, its blood supply, and we talked about how to differentiate its injury of spinal accessory nerve from that of long thoracic nerve. And along with that, there was a discussion of this triangle of auscultation. Then we discussed this large muscle. This was latissimus dorsi, its role in cuffing, its role in climbing, its function of adduction, extension, and medial rotation. And we talked about then of these three muscles, this levator scapulae, elevating the scapula, and this rhomboids minor and this rhomboids major, bringing the scapula near the middle head and the nerve supply. So here is a picture from the Keith Moore's clinical anatomy. You can pause this video here and go through the movements of the scapula we have gone through far. Which muscles are producing elevation of the scapula, marked as 1, 2, and 3. That will include trapezius, descending part, levator scapulae, and rhomboids muscle. So you can go all the way down this table. You can take a screenshot of this picture from Keith Moore's anatomy and revise. Thank you so much for listening. I hope so this had been helpful for you. If you have any questions or feedback or suggestions regarding this lecture, please mention down in the comment, and you may reach us through our website. By the way, all the recordings with presentation material is present there, and our Facebook and YouTube channel. Please feel free to reach out. If you have any queries and suggestions, please let me know. I will be trying to follow up with further lectures on the upper limb. Thank you so much.